15 companies that starting from a single person company with an idea and ending with a company which has a product that distributes all over the world. We have company not only from US, but also from other countries, from Ukraine, from Australia, and we hope that this vibrant community will generate more idea, more job, more creative energy that will ignite not only this small area, but the whole city, the whole state, and will be part of the flames that going through the wall. You know, incubator, it's maybe misnomer for this place, because incubator is something closed, warm, dark, where you're feeding. This is an open space where people not get fed, but they create something new. We hope, and I hope you will be part of this, to create the vibrant community. And when we started it with Rick Sousa, and we're looking at this empty space, in our wildest dream, we cannot imagine that it will be so many people who working here, who helping this. So far, it's mostly enthusiasm of few people who keep this place running. But I invite all of you to become part of this community with your ideas, with your time, with your money, just with your support. It's the only way we can sustain this for years to come. And that's what I want to tell. And now I want to introduce Kara Griffin, who will present a few words from the real businesses around here. Thank you, Kara.
Thank you, Russ. Hi, I'm Kara Griffin. I run the local Chamber of Commerce. And I agree with you, Russ. Yes, the building frame from 1 year ago looks fantastic. I just wanted to flash back about 3 years ago, tell you a little story. I got a phone call from a gentleman named Alex that talked about his vision, your vision here. And he asked me to come out and meet him here. So when I Googled it and realized it was in the middle of a container space, I was a little scared. And when I got here, I was even more scared because the space looked completely different. And while I listened and we talked and I thought the idea was fantastic, I was a little nervous, but you have come so far. The building itself, the parking outside, the hosting 15 companies is fabulous. Such an economic driver for our area. And I hope that you will flourish and we will flourish together.
Thank you. Thank you so much, Kara. That's really great, kind words, and I love that, and I look forward to working with you and everyone else in the Mansfield area community. Right now, I am pleased to introduce Jay Barrows, who is the stage representative for the town of Mansfield.
Thank you. It is still morning. It was a long night if you're a politician. I've decided I don't want to be one. But anyway, fun evening. I want to flash back about 55 years ago. There was nothing here. It was the Lowney Farm. It was where the cows roamed. I had a little pony I used to ride from the back of my yard through the woods. And Lowney was an industrialist that created Lowney Chocolate Factory, which is you pulled in here on the left. We're working to rehab that building into residential units, which will house folks that are going to work here. Probably about a $30 million project. And Mr. Lowney he figured it out. Had the cows, had the milk. I don't know where you get the cocoa beans, but you could smell chocolate. You probably still can if you go outside for years and years and years. But he was an innovator. He used the rail line. They put the chocolate on the train cars. They hauled it to Boston. and they put the chocolate into bottoms of the ship to keep it cool. And that was his refrigeration back in the early 1900s, which was pretty cool. This is really cool, because right here, what could happen with amongst those 15 companies, I think we're going to hear more from each of them a little later this morning, the innovation that can come out of here. It's funny, the word incubator, thinking about it, yeah, it is small, it is closed, it's something that you look at, but this is more than that. This is really a wonderful area to bring people together, to be creative, be thoughtful, and really to put Mansfield and Massachusetts on the map. And I know we're going to hear from Bob Coughlin, who's done an amazing job. I met him about 12 years ago, and he had as much energy as he does today. So the excitement that he brings to the biotech field and the work that you all are doing is really, really impressive. And it's so awesome for the Mansfield community, which is very diverse, very fortunate with our location, with our schools that are in the area, with the investments that we've made, and our future really is strong. So I look forward to hearing more. And again, I appreciate everybody coming out to our great community and being part of this. So thank you.
Thank you so much, Jay. That was fantastic. Now I have a pleasure to introduce the President and CEO of Mass Biotech Council, Bob Coughlin.
Thank you, Alex, and thank you, Russ, and thank you to all of you for having me here today. It's very exciting. I want to start off by saying why today is awesome. I got to leave the beautiful town of Dedham, Massachusetts, and head this way instead of towards Cambridge. And I had a beautiful ride. I didn't hit any traffic. I stopped and got coffee. It was wonderful. How many people have driven from this area into Cambridge? So I look like I'm about 80 years old. I'm really 22. It's, despite the traffic and the weather, we're doing pretty well here in Massachusetts with growth. And I want to talk a little bit about that. And what I thought I'd do is talk a little bit about how this amazing situation has happened here in Massachusetts around the life sciences. People say, when it comes to science, we're in the golden age of science. I think we're in the platinum age of science. The stuff that's going on here in Massachusetts is truly amazing, and we lead with science. I also want to talk about how the industry has evolved, and ultimately talk about how we got to where we're at, but more importantly, close out talking about where we're going and why this incubator is so important. Why Mansfield is so important, because it isn't just about Cambridge and Boston right now. That was the tip of the spear, and we'll talk a little bit more about that. But to start off, folks always ask, and again, congratulations to Representative Barrows. I mean, let's clap for him right now, and I'm going to tell you why. 16 years ago yesterday, I got elected to the legislature in Massachusetts, representing Dedham, Westwood, and Walpole. And that was the first day when I started learning how much policy could affect economic development, and more specifically, the life sciences industry. It just so happened I have a child with cystic fibrosis. So for me, the biotech industry was something that was very important, but what I didn't realize was that the men and women who serve in elective office could make decisions that are good for sick people, or make decisions that were bad for sick people in innovation. So as a policymaker, the years that I served in the legislature, I found out that government is just as important to this ecosystem as the science is, as industry is, as academia is. And we really embarked on a journey back then in the early 2000s to try to ensure that academia, industry, and government worked in a true partnership. And that's what differentiates us from not just everywhere else in the United States of America, but everywhere else in the world. I see my counterpart from the Massachusetts Life Science Center here, so great, Chris. And when you look at the fact that we have a life science center here in Massachusetts, a point of contact for this industry, I mean, that's a clear differentiator. That wouldn't happen without Jay Barrows. That wouldn't happen without the men and women that work in our House and Senate and the administration. Charlie Baker got reelected yesterday. I think that is fabulous, and I'm a lifelong Democrat. I love this guy. He's not a Democrat. I love him, right? So see what's going on here in Massachusetts, whether you're a Democrat or a Republican, people work together so that we can have an environment so this industry will flourish, right? That we take, I hope none of you take that for granted, because when I just think of my schedule for the past 2 weeks. I've been in, or 3 weeks. I've been in Austin, Houston, San Antonio, New York, Los Angeles, San Diego, Western Massachusetts. I want to talk about Western Massachusetts because we're on fire out there as well. It's growing across the Commonwealth. But to go to all these different places outside of Massachusetts and talk to people and have them say, geez, we wish we had that. We are so lucky, and the reason we are doing so well here is because of our partners in government, whether it's federal, we have a great federal delegation, local, state at the State House, and local. We see the town administrator here, and you're going to hear from him. You have a wonderful board of selectmen in this town. You're open to, all the town government folks here are open to promoting this industry, and that's key. We need to all work together. When academia, industry, and government are rowing in the boat together, there isn't a problem you can't solve. I already talked about the traffic. It's horrible. We're about to come into the winter. The weather's even worse. Workforce housing is an issue. Public transportation needs a lot of work, right? So we have a lot of warts and hairs and issues on what we got going on here, but we continue to grow. When did we open here? How many was the grand opening? 1 year ago, 2 years ago?
That's correct.
1 year ago, okay. Think about where we were at a year ago. Think about where we were at 5 years ago, and let's think about where we were at 10 years ago. MassBio now has close to 1,300 member companies. A decade ago, it was close to 400. In the last decade, Massachusetts has added 12 million square feet of lab space, and it's all filled. It's all filled. That's insane. We've grown employment in this industry by 38%. Average salary is about $130,000 a year, and we contribute about $28 billion a year in payroll when you look at the entire cluster. Like, it's truly amazing to see what we're doing for the economy here. And I think that's great. We're driving the economy and the life sciences here in Massachusetts, but also think of what we're doing for sick people. Let's go back 16 years ago when my son was born with cystic fibrosis. There was no hope. There was no hope. But because of companies like Vertex, FoldRx, Combinatorix, Epix, Altus, Alnylam, Alnara, to name a few, people that have been focusing on cystic fibrosis research, we're literally less than 10 months away for having a drug that's gonna save my son's life. So on top of what we do for the economy, to think what the beautiful men and women who work in this industry do each and every day, they help sick people. So I mean, I always say, Florida, man, you got the orange industry, that's great. Look what we have here in Massachusetts. We invent tomorrows, we invent cures. And I wanna talk a little bit about cures because that's where our healthcare system is broken. We don't have a healthcare system. We have a sick care system that was designed in the 1950s to pay for medicine that people take chronically. You know, you take your, use me as an example. I take my Crestor, I take my blood pressure meds, right? You take those in perpetuity. Well, what we're inventing here in Massachusetts now with gene therapy, CRISPR technology, Cas9 therapies, we're inventing cures. We're inventing breakthrough therapies that change the course of disease. And people say that these are expensive. Well, the best way to save money in the healthcare system is to cure somebody. Maybe there's a large upfront cost, but you save millions of dollars in avoided hospitalizations and chronic therapies. We don't have a system, a healthcare system that can account for costs avoided. But these are the things that we're working on right now so that when we have a cure for blindness, when we have a cure for cystic fibrosis, when we have a cure for Huntington's, Parkinson's, ALS, and Alzheimer's, we can afford to absorb those new therapies into the system. So those are things that we're working on. Now specifically to company creation, and that's where incubators come into play. We would not be the best place in the world for this industry if we did not have places that companies could start. Biotech 101. It starts because really amazing ideas happen in the 122 colleges and universities that we have in this small little state. Great ideas happen. Entrepreneurs say, come on, we're gonna take a chance. They take that idea and they're gonna turn it into a company. That is the most difficult aspect of this industry, turning something into a company. Where are you going to go? Can you afford $150 a square foot for a place to hang your hat and access fume hoods and access colleagues and work? That is so prohibitive. If we didn't have incubators across the Commonwealth of Massachusetts, there'd be no way that MassBio is on track to bring in 200 new member companies in 2018. 200. That's absurd. If you asked me 5 or 10 years ago if we'd be able to do that, I'd think you were smoking that legal marijuana now, right? But really, seriously, this is amazing. Last year we did about 190 companies. The year before, 180. We continue to grow. And if you look at the growth that we've experienced from 07 to 2012, when the Wall Street went away and the stock market went away, we continued to grow because we changed the model. We recruited big pharma companies to come here. We wouldn't have done it without the legislature and the Life Sciences Center. We wouldn't have been able to do it, and we wouldn't have grown like the rest of the country didn't grow during that period. We did, because we changed the model. Now what do we focus on? How do we keep the big companies here, the big pharma companies here? The only way we're going to keep them here is if we have the best workforce in the world. So workforce development and training is a big initiative that government is partnering with academia on. Workforce development, the best and brightest people, and then number 2, company creation. These big pharma companies came here because they want to see what you really, I say Massachusetts, these wicked smart people are doing here in Massachusetts. You look at the technology that's happening in this incubator, this is exactly what's going to keep the big companies here, because they want a front row seat to access and invest and partner and ultimately buy what you're doing. And, you know, I remember my dad in closing, because I don't want to use too much time. I could go forever, right? I love this stuff. I'm getting paid right now to talk about the only thing in the world I really love. This and fishing, and fishing season's over. So I might be here till next summer, Alex. So when you look at, you know, my dad told me back in the early 80s, I think I was sitting in the back of his, you know, maybe a 1981 Pontiac station wagon. No one was wearing seat belts. He probably had a Schlitz between his legs, and we were driving to a hockey game up in Waltham, right? So we're driving up Route 128. He said, "Kid, you know what this is? This is the information highway." And he goes, "You're going to go to engineering college, and you're going to be guaranteed to have a job at any one of these computer companies. Look at them, they're everywhere." By the time I graduated with my engineering degree, they were gone. Where did they go? They went to Silicon Valley. Why? Because we lost the bet as it related to the computer business, small computing. That whole industry went out to Silicon Valley. Why? Because academia, industry, and government weren't behaving. They weren't playing in the sandbox well together, and we lost an opportunity. And you can rest assured that that is never, ever, ever going to happen again, because we've learned from history. We're not going to lose this industry to Silicon Valley. We're not going to lose this industry to California. We're going to continue to grow right here because we know what it is that we need to do, and we're focusing on what's next. Digital health. Digital health is key, people, so let's pay attention to it. Let's continue to support our partners in government when they embark on a digital health initiative, because it's exactly what we were doing 12, 14, 15 years ago when we were sniffing around doing a life science initiative. That's how we became the best at this industry, and we need to do it in digital health too, with precision medicine, cures, wearables, how do you tie electronic medical records, everything from providers, payers, and innovators. The only way we're going to be successful in reducing the cost of healthcare and ultimately helping patients in building this new system is if we focus on digital health. And that doesn't have to happen in Cambridge. It doesn't have to happen in Boston. This is happening across the Commonwealth. It's happening right here in Mansfield. I'm so excited to be here. I can't thank you guys enough for all the work that you do. MassBio is your trade association. We go to work every day. The great people that work at MassBio want to service your organization, provide you with the programming that's required, to provide you with the business services that you need, the professional development that you need. And I hate to use the word lobbying. I'm not a lobbyist. I'm a patient advocate representative, you know that. But we're going to make sure that government does behave in a way here in Massachusetts and down in Washington, D.C., so that we can continue to help sick people. Everything that we do every day revolves around the patients, and I think if we put the patients first, we'll always continue to be successful. That's my story. Thank you very much for having me, Alexander. Thank you very much, Russ. It's great to be here, and congratulations on your anniversary.
Thank you. And Kevin, thank you for coming here. Thank you for all your support of our endeavor. And basically you touched upon a very important subject. We do need to remain number one. We cannot cede our primacy to the Silicon Valley. And on that, I'd like to segue this glorious event to Kevin Dumas. He is town manager for the town of Mansfield. Town of Mansfield has a key cog that would help Massachusetts remain number one. Thank you.
Thank you very much, Alex and Russ, and it's great to be able to have so many people here in Mansfield today. And listen, trying to speak after you, Bob. Class act, wonderful job. I have to say that I'm also a former elected official. I was mayor of my city in Attleboro for 14 years before joining Mansfield just about a year ago. And it's been a pleasure serving with John Stanbrook, our assistant town manager, and getting to know Mansfield, its people, its businesses, and what's going on here. And it was wonderful. I was brand new, and Alex reached out to me. And he said, I want to introduce myself. I want you to come see what we do here at the Mansfield Bio-Incubator, and to be able to show you why it's important, what happens south of the expressway, and why this is so important that this can happen down in this neck of the woods. And I have to say, certainly location, location, location. You know, where we are here with 95, 495, 140, we're perfectly situated between Boston and Providence, higher institution of learning, that the fact that we have such a workforce, diverse workforce that's available to us, and the fact that you have people and that you build relationships and those relationships matter. And so Alex reached out certainly to me, reached out to our state delegation, and we continue those strong working relationships, and also teaching us about life sciences and biotech. And I'll be honest with you, when I first started, I really didn't know that much. But when you get to see what happens in the investment that's being made to change lives, now and in the future and for future generations, it's amazing. And to see what happens here in this space in just 12 months from when you open your doors, and now to see that it's full. What an amazing success story, and that we're here participating in that with you and with Russ and all the people who are located here, because it is so important. And the fact that when you build those relationships, they matter. And they matter on a basis of when you need help, when you want to expand, when you have people that you need to be able to explain policies and initiatives, and that we need those strong partnerships in order to make a difference long term. And that when you need those partners, when you come together, you hear, you understand, and that happens first here on the local level. Then it builds up with our state partners, with our state delegation. Jay Barris has been fantastic, and the rest of our delegation. And of course, even when it grows larger, certainly not only with the governor, the lieutenant governor, but when we need our federal partners to explain what's happening here in Massachusetts, why we are number one, why we're expanding so quickly. And it's amazing to see what's happening here in Massachusetts, but specifically this region, and we're happy to be a part of that. And so anything that we can do, certainly, Alex, you know that with Russ, to be able to continue to partner with you, that we want to be able to see this grow. We know we have 100,000 square feet right behind this wall of empty space that we want to continue to see grow here in Mansfield, and that you have that continued partnership here with us and certainly with all of our delegation. Congratulations. We're so, so proud of you, and know that to continue the good work with you and all of your partners here at this location. Congratulations, Alex.
Thank you so much, Kevin. That was wonderful. And thanks again for everyone who came here. I'm very happy for you to show for us to show you the facility. Also, you'll hear the great research that's already going on in here. Where certainly I appreciate all the resident companies who spent some time preparing for the presentations, and also I'm very fortunate to have them choose us as a place to incubate their business. To grow this business, we obviously need to work as a team, including the government, trade association, the town, the biotech community, not just Massachusetts, but also the worldwide community. And right now, we'll have a short break for you to have a chance to eat and catch a breath. After that, in 10 minutes, we will be actually starting the presentation of our resident companies, and hopefully you'll enjoy it. Thank you so much. And once again, thank you so much for coming.
All right, hello everybody. My name is Abraham Seckler. I am the CEO of Gamma Therapeutics, a company we started this year. So just an extra special thank you to Alex and Russ. Putting this incubator together is really just the the perfect fit for what we were looking for our company. And I heard a few people talking about Silicon Valley, and really I love the industry that we're in and what we do. But there is no way you can start a company like ours or many of the others that are in the incubator here in a garage. And that fantasy of the American startup bootstrapping themselves in the garage is frankly illegal for somebody like us to do. Because we work with some of the nastiest bugs in the business, because we are trying to make hospitals safer and patients healthier. We are a photomedicine company, which is a very interesting approach to making sure that we're treating patients as a whole person and ensuring that their stays in hospitals, the symptoms that they suffer from, are all treated together. And you'll see we're putting together a few different technologies in combination to make things a little bit better for everybody. Step back here. So one of the things I think that's very important is at the heart of everything that we do is overcoming antimicrobial resistance. Now, we've all heard about that, and I'll talk about that a little bit more. But the fact of the matter is, and I'm sure you've all heard it, is that we're losing the battle against infectious diseases. It's overuse of antibiotics. It's the conditions in different hospitals. And the pharmaceutical industry has frankly failed us. And it is up to us, smaller companies, startups, to come up with the solutions to help take care of those pathogens while addressing and minimizing resistance. So what are we trying to do here? What is our mission? So we want to make sure that we are developing new types of therapies and treatments for patients that are suffering from infectious diseases. We want to provide complete solutions for dealing with antimicrobial resistance. There's all kinds of great stuff out there. There's been a lot of advances in technology. And one of the things that we drive is using the cutting-edge technologies that are found, that have been developed in the LED industry, combined with some previously untapped opportunities for antimicrobial products, as opposed to relying on things like antibiotics. But also what's been very important is you can't do this in a vacuum. We've had to develop some very important partnerships to develop the types of technologies we're working on. We've had to become an advocate for photomedicine and explain really what that is and how that can integrate into our healthcare system. And really what is very important to me, and we've heard a lot of talk about here today, is integrating into the local economy, into the local business structure, so that we have an opportunity to bring some very large sources of federal funding here locally to places like Mansfield. What do we look like? So we are a team of engineers, scientists, commercialization experts, regulatory experts, and medical advisors. We put this company and this team together early last year, and with the sole focus of taking this a few different pieces of key IP and developing a number of products around it. We also, as I said, haven't been able to do this in a vacuum. We have to rely on important types of research partners. We've written grants with Harvard University, with Oxford University, the University of Wollongong in Australia, here locally as well as internationally. And we'll rely on very important industry partners to help bring expertise that we don't have in-house, like optical engineering and even pharmaceutical manufacturing. We can rely on a company like Patheon has written letters supporting all the grants we've put together to ensure that any of the pharmaceutical products that we're looking to develop, they can manufacture and we can scale up. So how we came about in the past year, just over a year, we secured about $2 million in seed funding to get us to this point, to get us here in the incubator, get the equipment that we need to do the research and development to chase after those key milestones. Part of that is part of an Army contract that was as part of an SDIR-2, where we're developing a device, which I will show you, how it works and what the end goal for it is. Part of that is developing another device for wound disinfection and pairing that with some pharmaceutical products. What we've done in the time as we set up the lab, we put together a really top-notch grant writing team where we've been able to, if you see here, we've applied for $10 million of grants already in the last 6 months. That only includes the NIH and some of the SBIR grants we filed for. That doesn't include also a number of DoD grants and private white papers that we've put together that actually that number, if you include those, is close to $20 million in just the last 6 months alone. Now, are we going to get all that? I hope not, because that would be a nightmare to manage. but what we're looking to do is take any one of those grants, bring those federal funds here locally, and run clinical trials, clinical use studies, some late-stage preclinical testing, everything that you need to get through those key regulatory milestones to have a viable technology ready for scale-up. And who do we work with? We do a lot of work with the Department of Defense. Our current contract is with the U.S. Army, but we're actively soliciting a number of the program managers across the board. We're also working with the NIH. So we've applied for both R01s and fast-track grants, and there's a number of others that will be coming up next year. So this is what we've done already in 2018. 2019 is only going to be busier. So now let's talk about the technology a little bit, and you can't do that without talking about that we are in the era of resistance. You may have seen some of these headlines. You constantly see them. It's becoming more and more frightening, and I'm not here certainly for any fear-mongering, but the problem arose back in the 80s, and we really ignored it till now. And every one of you, either directly or indirectly, has experienced the effect of this, whether it's you go into the hospital for one particular issue and you come out with a C. diff infection. People will have MRSA infections that extend a stay long beyond their planned surgery or whatever it was they went into the hospital originally for. And it is an enormous healthcare burden and an enormous risk to any patient that gets in the hospital. My wife recently had our second child, and she that was the one thing the drum I beat over and over again. I said, let's get in, let's get out. Let's not spend any more time than necessary there. So what does this look like? And I think this is a very important slide because it gives a good sense of what has been going on in the industry for the last 100 years. In that top row, you can see all the key discoveries of different classes of antibiotics. On the bottom, these are photosensitizers, and I'll talk about those in a second. But what's important is you can see this is the very last class of antibiotics that was brought to market by all of our friends in large pharma. And since then, there hasn't been any developments. The reason for this, some of you may know, but the reason is because it's simply not, the return on the investment simply isn't there anymore. Because by the time you run a clinical trial for a new antibiotic, you've already developed resistance in that clinical trial. And so the very organisms you're trying to treat, they're already out there and ready to circumvent the new therapy you've developed. And that's why since about the mid-'80s, there hasn't been any new serious classes of antibiotics released out there. And that's what the era of resistance is. That's what I'm talking about. And that's what we're looking to circumvent. This is what we're looking to do it with, is photosensitizers. So we have hardware, we have medical devices that we are developing, but in the same time, we are developing pharmaceutical products to make those medical devices more effective to disinfect and speed wound healing, and to make the hospital safer. And patients with chronic unhealing wounds, we'll talk about those in a second and what those look like, because we're all familiar with them, to make it safer and allow them to use this very robust and very prolific field of photosensitizers to create antimicrobial products that we don't have to worry about things like resistance in. So, talk a little bit about the technology here. The first device that we're working on as part of that U.S. Army contract is for point-of-care disinfection. This is a non-therapeutic technology that uses LED light to disinfect intravenous catheters. Now, the goal here for the Army is to develop one that can be used in the field. So it has to be very robust, and that's in fact what we're starting with here in the lab. What's very important is this can be used as a countermeasure for any type of infections, including more difficult biofilm infections. You think of where the modern warfighter is stuck these days. There's all kinds of nasty fungal infections on top of your regular microbial infections that need a type of therapy to address it. This is a device that will use light to help sterilize and make it safer for them before they even make it to the hospital to be treated. The other technology we're working on here is a therapeutic one. This is for the wound healing. This is a light-based device that will be applied to a chronic unhealing wound, things like diabetic foot ulcers, severe burns, skin grafts, pressure ulcers, any place where you have a wound that is slow to heal and potentially a patient that is additionally vulnerable because of their current health state. We have designed this technology, again, not in a vacuum. We want to put together a therapy and a pharmaceutical solution that will work with it in tandem, create a technology platform that is more effective working together than it would be as its individual parts. So what does that pharmaceutical pipeline look like? So we have that light-based platform that we're using, and we're pairing it with some of the most cutting-edge pieces of technology out there. So if you look at, we have hybrids, we have molecular nanomachines, and we have Perkins. Each one has its own advantages and disadvantages, and are at slightly different stages of development. But the idea is that we'll combine any one of these, and this is much of what our grant authorship is around, combining these with the technology individually to make that medical device more effective and to allow them to heal patients faster, alleviate many of the symptoms that come along with pain and the potential for infection. One of the most exciting here, all of these are cutting edge. The molecular nanomachines are in the earliest stages, but it is also one of the most exciting pieces of technology. We are really looking for a number of opportunities within the NIH to take something that until this point really hasn't been able to commercialize, show that it can make a viable pharmaceutical product, and it will be specifically tailored to work with our medical devices. So just to give you a sense of an idea of where we are in development, those molecular nanomachines, as exciting as they are, those are in the very early stages, and that's okay. That's what those R01 grants are written around. They're specifically designed for technologies like that. We've also put together the fast-track grants and some of the SDIRs for our Perkins, as well as our hybrid technology and photosensitizers. Those are for discovery to very early stages of preclinical development. We're doing some screening, we're putting them together, we're working with very small volumes of these things to show in vitro that these things can work, while writing the grants to show that this will work in vivo. When late-stage preclinical development, we have both our medical devices. These we have written some very large and very extensive grants for either transition into clinical use studies or for further in vivo development. So the question I always get asked is, well, what does the market size look for these things? And this is just a small slice. For wound care, now, an important thing to look at when you look at the wound care industry is there have been no advances in this technology in 40 years. And that's those silver-wrapped bandages you see, the antimicrobial bandaging that all these companies out there, these manufacturers, make a very significant profit margin on, but really have not changed in any amount of time. And so we rely on that, and we rely on a technique called wound debridement, which I won't get into the details of, but is frankly horrifying and has been done for about 100 years. We are looking to change and create new standards of care in both wound care and disinfection, where not only will it just be better than what's currently done in the industry, but it will be required to follow our protocols, use our types of technologies, because it is patently safer for patients, it reduces cost burden on the healthcare system and makes hospitals happier because they don't have to shoulder the burden of the cost of HAIs in places like the ICU or the clinic. And everything that we do right now is also being designed for the soldiers out in the field to make, when they are at their most vulnerable, to make it safer for them and reduce the rate of infection while increasing the chances of avoiding any kind of morbidity and mortality. So I'm going to leave it there. This is, again, that's my name and all my contact information. You can go to our website as well. We have some information up on there. I'm certainly very happy to talk to anybody about it. We have our CSO here as well, so we're definitely very happy to talk about some of the technology and everything that we're putting together. And again, thank you to Russ and to Alex for putting this all together.
Fantastic presentation, Abe. Thank you so much. Next would be Gradient Research. Kathleen, come on in. Gradient Research is developing a thermal therapy as a replacement for surgery for skin cancers and other indications.
Thank you, Alex, and Russ as well. This has been a great place to work, and I'm so glad you opened it up. And I've been here since July 1st and have gotten a lot of work done. Also, Alex has been great in providing helpful hints on cell culture. That is one of his areas of expertise.
Bring your microphone.
Oh, okay. Okay, thank you. So, Gradient. First of all, my name is Kathleen McMillan. I have a PhD in physical chemistry, and since I got my degree, I left academics and have been working in the field of medical applications of lasers. I've been in this field for 25 years or more. I started as a scientist at Candela Corporation, which you may know of as a medical laser developer, one of the original ones for dermatology and many other fields. I spent a few years in New England Medical Center and Tufts School of Medicine in the otolaryngology department. And then I returned to Candela as VP of Research, elected to the board of directors of the ASLMS, and then most recently founded this company, Gradient Research. So Gradient. Gradient has a platform technology, and it's based upon a precise form of thermal therapy, and the objective is to replace excisional therapy with thermal therapy, which is non-excisional. It works by initiating a biological response to unwanted tissue, which could be tumor cells, it could be disease cells, hypertrophic tissue, without wound formation. That is, there's no vaporizing. If you think of lasers and how they normally work, it's by cutting or vaporizing or burning. But there's none of that with the laser thermal therapy that's being developed. It's a platform technology that's applicable to a wide variety of procedures, but as a business, we're focusing on two particular procedures right now in otolaryngology and dermatology. I have as medical advisors Tom Rohr, who's a physician in Chestnut Hill, also the immediate past president of the American Society of Dermatologic Surgery. He's a Mohs surgeon, which is, skin cancer is one of our big applications. And Kristen Kelly is a professor of surgery at UC Irvine. In the otolaryngology field, Rahul Shah is a professor of otolaryngology and pediatrics at Children's National in DC, the Children's Hospital in the DC area, and Tulio Valdez at Stanford University. Actually, Rahul was a medical student and Tulio was a research fellow when I was at New England Medical Center. So how did I go from, my PhD was in the area of supersonic beam, high resolution spectroscopy of van der Waals molecules, as esoteric as could be. Went to Candela to start working on tissue, which is as complicated but as practical as you could get. how did it turn into this interest in thermal therapy? It actually started fairly early in my days at Candela. I was just doing a lot of reading because when I started there, I didn't know what an erythrocyte was. And I was reading a lot of the medical literature, and I ran across an article talking about this disease called papillomatosis, where these benign virally induced lesions would form on the vocal cords. And at the time, they were being burned off by using a CO2 laser, which essentially vaporized them. And the problem was that these lesions would occur often in children, and they would reform because they had a viral cause. And so these children would have multiple procedures in which these lesions were burned off, and eventually the vocal cords would be affected by the scarring that's an inevitable consequence of burning tissue. And I thought, well, what if instead you could use a laser such as we were developing for port wine stained vascular birthmarks and shut down the vasculature of those lesions? Well, I was not as old and wise as I am now, so I went to the chief of otolaryngology at New England Medical Center, who is a pioneer in the use of lasers and an expert in the use of CO2 for papillomatosis, and said, I have an idea for a much better way to do this than you're doing now, which is scarring people. And fortunately, he didn't throw me out of the office. He listened, and we tried this first in an animal model, and I got SBIR funding at Candela. He asked me to come and be the director of the Otolaryngology Research Center, and there we started doing clinical research under a phase 2 grant. And now this treatment is a standard of care for the treatment of this condition. Another thing that was being done about that time at New England Medical Center was treating tonsils with a laser. And this shows that the light isn't ideal, but you see here on the left, this is an animal model. Those two arrows show the tonsils in this animal model. 7 days after treatment, where the tonsils are basically heated up with a laser, just passing a laser, a non-ablative laser, a near-infrared one, over the tonsil while simultaneously dripping saline on it, that tonsil is shrunk. And if you looked later, it would have disappeared totally. But there was no wound during that whole formation. That was a great idea and really remarkable. It was unexpected. But the way they were doing it was impractical, and that was 20 years ago, and it never went beyond that animal model work. So what I wanted to do at Gradient was to take this interest in thermal therapy, apply it to medical conditions, and looking at the problems that I felt like could really benefit from the non-excisional, non-wounding nature of the disease. So the first one, tonsillectomy, based on that original work. There's right now about 750,000 done a year, 80% of them in kids with hypertrophic tonsils that cause sleep-disordered breathing, and 20% in adults. It's mostly infectious conditions in adults. Adults are very undertreated because the procedure has such morbidity in adults. You're off of work for 2 weeks. It's estimated that there will be 1 million tonsillectomies a year if you treated all adults who could benefit from it. This is a child with hypertrophic tonsils, and you see the blue arrows there are pointing at the tonsils, and they're quite large. The tonsils can be 2 centimeters across and practically obstruct the airway. 7.6% of kids have to go back, most of them to the ER after having a procedure, after having tonsillectomy out. It's painful. They're dehydrated because their throat hurts too much, and that causes dehydration, vomiting, nausea, and leads to them revisiting. With adult, the numbers are 12%. It's even more morbid in kids, but it's described as having 100% misery index. The reason is that what's being done now to remove the tonsils is excisional, and it doesn't matter how you do it, you're left with a wound on the pharyngeal wall that leads to inflammation and stimulation in the nerves, and that pain is significant and it's long-lasting. So compare that picture to what I showed you here earlier, where the tonsil is never cut. It simply shrinks away. What I wanted to do was to take that concept, that goal that we saw 20 years ago in the animal, and start with a blank slate and say, how can you develop a procedure that could be used in patients that's safe and effective in a wide variety of tonsil sizes or tonsil conditions, and have come up with the objective specifically of saying, we want something that's bloodless because there's no excision. That's one reason it makes it rapid. Rapidity, of course, is reduced OR time, and you know how expensive OR time is now. Reduced time under general anesthesia is important for children. Because there's no excision, there's no wound, there's little or no post-op pain, dehydration, or readmission. It could be done in the OR just like an ordinary tonsillectomy, but it has the potential to migrate into the clinic or the office. It reduces the economic burden of a high-volume procedure, but most importantly, is just as effective as a traditional excisional tonsillectomy. So there's the large tonsils. Tonsils can vary in size from small to large that need excision. What you need is a device that reaches in and grasps the tonsil, compresses it between those two light-emitting surfaces shown there with the air, that helps reduce the blood flow, that in turn reduces heat loss during irradiation. The radiation occurring at those surfaces shown in white there, that's a sapphire window. And the compressed tonsil then, the mucosal surfaces are cooled by cooling that's passed through the surfaces of the window. And the laser light heats up the interior homogeneously, the tonsils. And we've chosen a wavelength based on the ideal properties of the tissue. We've developed a novel optical design for making an extremely thin applicator surface with a sapphire window at the bottom, extraction features above it, and then a cooling layer above that, so that the whole thing could be just a couple millimeters in thickness and fit around those very large tonsils in the child in the operating room, where the physician has a very narrow field of view. We've shown that we're able to get even energy distribution out of that kind of optical design, which we had to develop a new optical design in order to get this kind of irradiance over a large area from a very small laser fiber. Then we have a disposable element which has temperature sensors that snaps on to the end of the light-emitting ends of the forceps and allows the temperature to be monitored during the time that the laser's on, so that the physician can apply just the right amount of light to heat the tonsil for an optical result. We've done preclinical collaborative research with a pathologist who's an expert in thermal therapy. He's done a lot of work for different companies, including RF companies, on fresh tonsils from the operating room, and have shown that we can induce damage to the lymphoid cells without damaging the blood vessels, which are shown in this bottom left section here, which are stained dark. And that's important because you don't want the tonsil to be heated so that it becomes necrotic and sloughs off. That would be not the clinical endpoint you want. You want it to shrink gradually. And for that gradual shrinkage to occur, you have to have a blood vessel system that's intact. And we've developed new technology for quantifying the amount of thermal damage that allows us to develop an algorithm that gives us intraoperative control of the device so that the physician knows exactly when the right amount of heat's been applied for damage to the lymphoid tissue, which you want to eradicate, without damage to the blood vessels. The regulatory path is clear here. We have there's a device which clinically is not accepted because it heats but very inhomogeneously and incompletely and unpredictably, but there's a 510K we can use, so it can be a predicate device. The existing CPT codes are appropriate for the new procedure. So we don't have to get new codes, which is a great time saver. Eventually, though, as the product does move into the physician's office and the procedure is done under sedation or even under local anesthesia with adults, there would be new codes required to differentiate from the other procedure. But this would be down the road. And then just quickly some financial projections based on, there's a relatively small number of ENT surgeons, about 4,000, and assuming that, because they tend to work together, that one physician would share two, you have a certain number of devices. Reusable forceps, we don't want people to be throwing away optics. We want to make this cost effective. So our disposable is that little bit that clips on with the temperature sensors. And most of the revenue generated would be from that device. Just quickly, non-melanoma skin cancer, it's the same problem. And I'm sure it's likely that someone in here has had basal cell carcinoma and it's been treated surgically. Often now the mainstay is Mohs surgery, where the physician step by step excises a little more, looks for the tumor cells. If he finds them, goes back and takes a little more until he gets down to the point where there's no more tumor cells. The reason they do that is because the tumor cells are mixed in with normal tissue. You can't simply, it's not like some kind of solid tumors where you can see where the tumor is and where it isn't. So it's inevitable that you remove normal tissue along with the tumor cells. What we found is that the tumor cells of non-melanoma skin cancers are more susceptible to heat than the collagen and the normal dermis around them. So we want to replace the Mohs surgery, the excisional surgery, with a thermal therapy to do that. Right now, Mohs surgery, it's a significant healthcare burden, $4.8 billion in the U.S. alone. And because of the aging baby boomer population, that number is increasing. So I asked Tom Moore I sort of preparing the talk, and I asked him one day around noon on a Friday, could you send me a before and after picture of a Mohs surgeon? And he goes, sure, I'll take a picture this afternoon. And then I thought, oh, wait, I don't want him to send something too horrifying. And then on a third thought, I thought, no, let's just, for me as well as the audience, just see what he would be treating that after Friday afternoon in his office in Chestnut Hill. So this is a patient, and fortunately the screen's kind of small, so it helps. But there's a tiny little basal cell carcinoma there. I think, most people would be challenged to see that. But by the time the Mohs surgery is completed, you see how much skin is excised. And that just doesn't heal by itself, obviously. It has to have reconstructive surgery that adds to the cost of it. So this is what we want to replace with a non-invasive, non-excisional, light-based treatment. In this case, we're, as I mentioned, irreversibly damaging the tumor cells, but not irreversibly damaging the normal skin around it. That's difficult to do, but you can do it when you do it with precision and monitoring the temperature, as I described before. We can also increase the discrimination between those two components by adding a topical drug that makes the tumor cells more susceptible, but doesn't affect the normal tissue's sensitivity to heat. So we end up with a combination product that comprises a laser with a sensor handpiece and a display that the physician can watch the procedure and know when to stop it, along with an application of a topical drug. And here, just briefly, estimate the financial projections for that. There's more dermatologic surgeons, those are the people who do Mohs surgery, than there are ENT surgeons, about 6,400. But again, assuming a certain amount of sharing the device, assuming we have a laser system and the optics are reusable, and we just have a disposable temperature sensor, because that penetrates the skin slightly, it's something you don't want to reuse. And then the drug, we estimate a total annual maximum revenue just in the U.S. of $1.8 billion. There's a very strong patent portfolio that these patents are assigned to Gradient. We have 3 patents in the area of the photothermal platform technology. In the middle of October, received a notice of allowance on a second one for the apparatus. In May, received a patent for skin cancer thermal therapy, and just last Friday, got the good news that the European office has given us a notice of allowance for the European. So our market is going to be protected by our patents in the US and in Europe. With this recent, obtaining all these most recent patents, and the skin cancer one, as I may have said, was in May, started initial fundraising, and I'm talking to a group of otolaryngologists. The syndicate leader is an otolaryngologist who has a lot of entrepreneurial experience, to put in place a $500,000 investment by the end of this year, and then proceed to raise another $1 million, and following that, as needed, grant applications, as in the SBIR that I've done in the past, and any additional equity financing to get $3.5 million for early clinical studies in both the skin cancer and the tonsillectomy over the next couple of years. So that's it, and if anyone wants some more information, I'll be glad to give it to you.
Thank you so much, Kathleen. Fantastic presentation. Mike?
It's mainly to build the clinical prototype device. And at that point, we're thinking $1.5 million.
And the second question is, based on your economic projections and assuming scale, do you think you'll be able to sell this in Asia, where there's far more head and neck cancer than there is in the United States? Far more prevalent, far more incidence too.
Yes, that's a possibility, and we in fact have, I didn't show it in here, but a device where rather than having the light come out of sort of that forceps I showed you, it's instead a device for irradiating a luminal surface, say the esophagus, where the light is irradiated on the outside of that device, which is cooled. So again, you preserve the normal tissue but treat the...
So that's a gigantic market, far larger in terms of patients than the U.S. So I wonder if you consider regional maybe that would be...
It would certainly be something that could be important for us. Thank you. Yes.
So, with respect to combining with medical drugs, would that be one of your regulatory drugs, like food that's out there, or more traditional oncology? And are there, I know you said damage to certain strands of the cells. Can you affect this on the cells so that it boosting those combo?
Yes. Yes, the question is sort of a little more information about the topical drug. There's more than one topical drug that we see in cell culture experiments is having an effect on the tumor cells. And the question is going to be finding the one that's optimal may come to the difference in its effect on the normal, say, the normal fibroblasts in the area. But the topical drugs, what we've seen so far is that the topical drugs, there's a couple that we tested that are already on the market for dermatological applications that enhance the susceptibility of the tumor cells without enhancing the others. And the immune response can come in a lot of ways. I personally think the immune response comes in to this with any drug that you're using. You know, just pulling an example, not necessarily what we're working with, but imiquimod. Imiquimod will have an effect on just the cells alone, but clearly it has an effect in vivo and clinically that involves the immune system. But it works with isolated cells as well. So, does that answer?
Yeah.
Yes.
Do you really have a solid understanding of the biochemical mechanism that causes tissue to shrink and reduce?
It's been the subject of a lot of, somewhere between discussions and arguments. I think that there may be a combination of necrosis and apoptosis that's occurring. Dr. Code feels strongly necrosis is the mechanism, but I think it would be interesting, although it's perhaps, well, you can argue too whether it's an interest in science or an essential part of the development, but I'm interested to know the extent to which apoptosis may play a role, either with the laser alone or with the combination with the drug.
The next presentation will be by a company called Hilltop Biosciences, and they have a novel product to help regenerate connective tissue in animals. Thank you.
Thank you, Russ and Alex, for having me here today. I'm Amanda Drobnis, the co-founder and CEO of Hilltop Biosciences. We're an early-stage veterinary biotech company providing therapies to injured animals to regenerate and restore full functionality and long-term health. About 7 years ago, I had a hip injury that prevented me from riding my horse, but especially prevented me from doing everything else. And so I ended up having one of the first placental allograft injections in my hip for orthopedic indications. It's been about 7 years. I only had that one, and I'm great and feeling fabulous and back to riding. And so I started my own distribution company selling these allografts to doctors and hospitals throughout New England. And about a year after my injection, my friend's horse, pictured here, Susanna, had an injury to her hind leg. And the thought occurred, why aren't we using these allografts? It works so well for me. Why aren't we using them for our horses? And so we did eventually use it for her, and she did fabulous. But I did reach out to the company I was distributing for at the time. And it's since been a long 5-year journey, but we're finally on the verge of getting funding. So we're finally here. So what's an allograft? An allograft is a tissue from another donor. So in this case, we're using placenta and amniotic fluid as our allograft. Both the placenta and the amniotic fluid have all of the components and proteins you need to grow a baby, whether that's a foal pictured here, or a puppy, or a horse. The placenta and the amniotic fluid are typically discarded after birth, but if we collect it quickly, those proteins and components are still viable. So those proteins and components also allow for it to be antimicrobial, antifibrotic, anti-adhesion, and anti-inflammatory. All of those things allow for it, when it's applied to an injury, allow for it to heal quicker with less chance of infection, which we all talked about earlier with the earlier presentation, and allow for minimal scarring, which we just talked about too. So all of these components and proteins make it a far superior product to what's currently on the market, which is just stem cells in certain regenerative therapies. Doctors and veterinarians have actually known about it for over 100 years. There's reports all the way dating back to 1910 in ophthalmology, all the way until today in cardiology, ophthalmology, orthopedics, podiatry, you name it. There's a study about it. And it's extremely effective. In all of those research, there have been no adverse events ever reported, which is pretty impressive for any research. So why am I even doing this then if everybody knows about it? So veterinarians and doctors typically don't use it because it's extremely hard to get. So it's hard to clean, obtain, store, all of those things. And 90% of our veterinarians actually turn to other therapies, which are not as effective, can have adverse reactions, require multiple treatments, and specialized equipment. So they're turning to things that are just not as great. We have an opportunity to fix this. We have exclusively licensed the IP and have additional patents for a room temperature, easy to use, highly effective placental allograft. These allografts are quick to administer. They provide a consistent dose every time. You can use them across all breeds, so you can have any kind of horse or dog or animal. You can use this. It does need to be species specific though. It's cost effective for our animal owners, providing an easy to use alternative. It has high margins for our veterinarians and for us. And as I mentioned, it's minimal risk. It's also a proven indication for wounds, eyes, tendon and joint injuries, think arthritis. And then we have a variety of other indications that we're looking into as well. We're focusing first on horses because on any given day, roughly 20% of the 6 million horses in the US suffer from an injury or illness preventing them from working. This equates to about $1 billion in lost revenue a year for the industry. The equine regenerative medicine, so just horse orthopedics alone, is $500 million. Then we're looking further into the larger subset of that, which is the US veterinary care market, which is a $17 billion industry. We will focus on horses and then move into small animals, dogs and cats in the future. So just to compare current standard of care versus regenerative therapies that are on the market versus the amniotic or placental allograft that we have, you have your standard of care, which can take up to a year to heal with only a 20% chance of full recovery going back to previous levels of work. Then you have our other regenerative therapies, which take about 240 days, sometimes less, sometimes more, with a 58% chance of full recovery. And then you have us, which has 75 days to full recovery with an 83% chance of going back to previous levels of work. So to look at it a different way, you have your pharmaceuticals, which are standard of care. Those pharmaceuticals are corticosteroids or other drugs that we use for our horses. As we know, pharmaceuticals are mostly just a Band-Aid and not a cure, like we talked about earlier. Then you have your PRP, which is platelet-rich plasma, adipose and bone marrow stem cells, and IRAP, which is sort of a mixture of PRP and stem cells. Those are your regenerative therapies. None of the regenerative therapies on the market are room temperature. They can only be used for a small subset of orthopedic indications. And none of them are easy to use. They require specialized equipment. So out of all of those, we have an opportunity to provide a highly effective, easy-to-use product that can be used for all sorts of indications. We did some research to determine exactly what our veterinarians were willing to pay. What do they use regenerative therapies for? How do they use them? Have they heard about placental allografts in the past? Here you can see our research. So our plan is to have our average price point be at about $500 with an opportunity in the future to have a more pure product or something that has higher amounts of proteins or something like that for a higher price point. We did some beta testing with 50 cases, 9 veterinarians across the US with an 83% effectiveness, meaning that they returned to previous levels of work within 75 days. Here's some of our products. They're mostly acellular, so we have an injectable and a membrane for a variety of different indications and different uses. So our team, I'm Amanda. I have about 10 years experience in regenerative therapy sales, both in human and animal. My co-founder, Mark, has 20 years experience in veterinary medicine. He has an established network of elite veterinarians, has led large sales teams. We have Siobhan, who is our CFO. She's worked with many emerging companies, starting out from where we are, which is needing funding, all the way to a merger and acquisition. On our science advisory board, we have our veterinarian with 20 years experience. He's used amnion in the past with excellent results. Dr. Werber and Terrell Sudarth are our 2 inventors. Dr. Werber also happens to be my father, which is how we have the exclusive license to be where we are today. They have their own human allograft company they just received funding for, so they're really focused on the human side and not so much the veterinarian side. But they will help us along the way. Just some financials. We expect to break even within 3 years, have sales with about $25 million within 5 years. This is for both horse and dog in the US only. And our gross margin is about 70 to 75%. So, in summary, we're developing and advancing animal therapies to regenerate and restore full functionality. We have a superior solution, a unique intellectual property, unmet need, and a knowledgeable team. Thank you so much for having me.
Thank you so much, Amanda. Great presentation. Does anyone have any questions? Anyone else?
So there is a veterinary FDA. This is considered a medical device because it's acellular treatments. We're not using our stem cells. So we follow medical device, which is a much faster regulatory. It'll only take a few months to get approval to sell versus as a drug on the veterinary side. Anybody else?
Okay, great. Well, thank you so much, Amanda. Next will be in novel bioanalysis, Honi, and she'll be talking about her novel mass spec assay.
First of all, I would like to thank Alex and Ross for putting this together. This is amazing to see so many people coming today. And actually, I talked with Alex and Ross 1 year ago, and during that time, it was like very much just wars. And now it's amazing to see how much has been developed. So I'm Hong Ying-Gao, the CEO and the founder of Innova Bioanalysis. A little bit of background about myself. I was senior principal scientist in discovery bioanalysis at Pfizer before I founded a startup, and I have stayed with Pfizer for 8 to 9 years. Prior to that, I was a scientist at Vertex in Cambridge, actually. So it was amazing to see Vertex now is flying very successfully with their cystic fibrosis drug. So I founded this company is because I think there's a really big issues in biotech and a pharmaceutical company and the industry-wide problem. And I will show you in the following slides. I think this is the laser doesn't work. So our mission, the reason for me to found this to found the company is we really want to innovate so that we could tackle the disease in unmet medical need. So with this biotech and pharmaceutical industry experience, I think you probably would know that it's big challenges to develop drug. And here a little bit of background about the failure in the drug development. The top reason for drug failure at the later stage is lack of efficacy. And you can see this plot here. Safety counts about 25%, but the efficacy counts more than 50%. Especially at the later stage at phase 3, you will see over 55% drug failure or lack of efficacy. And combining with safety issue and efficacy issue, you will see about 80% drug failure in later stage at phase 2 to phase 3. So as a matter of fact, still at this time, we are just better off not to find a new drug. And you can see that this is not just for one therapeutic area. This is across the board. Even for oncology, we see a lot of breakthrough in recent years in developing new target and new therapeutic development. Still, the lack of efficacy or lack of validated target is still an issue for developing drugs in oncology. So that's why we want to develop novel technologies to do biomarker. And the reason for biomarker analysis is critical is it will be able to help us to meet these challenges in biopharma and pharmaceutical industry. It will facilitate the disease diagnosis and identify population at risk, and also will help us to assess disease progression or regression and monitor the responses to treatment. And also, most important is to serve as surrogate efficacy endpoint in drug discovery and development. And this is the most important part for diseases with a very complicated mechanism or unknown mechanism. So to bring up to a specific disease we're currently working on, you probably all heard about the non-alcoholic fatty liver disease. It is a disease, epidemic disease, affect almost all populations in the world. And it is a liver disease which is excessive fat stored in the liver in the absence of significant alcohol consumption, or called existing liver disease. And you can see this normal disease on the top of the figure here, and then the fatty liver disease, you can see the fat cell deposited in the liver. And the NAFLD is a world epidemic liver disease. It's affecting United States 30 to 40% of the population. The rest of the world is about 30%, and Asia is increasing between 15 to 30%. So at the present time, it is estimated the prevalence is about 25%, and it's about like 1 billion people affected worldwide. And this number actually is a conservative estimation because it became much more common because the rising incidence of obesity, type 2 diabetes, and metabolic syndrome. So here shows a progress of the NAFLD disease. And you can see the healthy liver at the beginning will have some fat deposit in the liver. So that's beginning stage of NAFLD disease. This actually is a disease which can be reversible. So physicians would recommend people to do exercises and a diet, and a lot of physicians are saying, only 5% of patients will do such thing. So a lot of people wouldn't really control their diet or begin to do more exercises. And after the NAFLD disease, once it progressed to NASH, which is non-alcoholic steatohepatitis, that's the most severe form of NAFLD, and then it becomes irreversible. Then you begin to see liver inflammation and cell damage, and then about 15 to 25% of the patients with NASH may develop into cirrhosis, and then eventually develop end-stage liver disease, which require liver transplant or even develop liver cancer. So NASH is a very important stage of the disease, which is important target for the pharmaceutical company as well. It currently affects 12% of people, and it's about 30%, meaning actually this number is conservative. I think the latest is 35 million people in the United States currently. And it's estimated to be the leading cause for liver transplant by 2020. The annual medical social burden for NAFLD and NASH is about it's about $292 billion in the US. So the NASH is really an unmet medical needs. The reason for it is NAFLD and NASH both have very few or almost no symptoms. And then there's no clinical variables can differentiate the NAFLD and the NASH. NAFLD usually can be diagnosed with ultrasound, and that typically can be done quite easily in physician's office. But there's no differentiation from NAFLD to NASH, so that's very challenging for the physician to take care of the patients. And currently also there's no drug approved for the treatment of NASH. As you know too, there are a couple candidates in the current late stage of clinical trials. However, their mechanism or therapeutic mechanism is not approved. So still, as a matter of fact, for the whole scientific community, there's no validated mechanism. It is said or mostly accepted that a complex mechanism is involved. That may involve parallel mechanism and interplay with each other in the disease progression. So the only definitive diagnosis for NASH is liver biopsy. And that is also required for later stage clinical trial by FDA to develop a treatment for NASH. And the liver biopsy actually can only give a category type of diagnosis. It cannot monitor the progression of the NASH severity. On the other hand, liver biopsy is fully accepted by patients because it's very invasive and highly painful and also has potential for complication. So there's an urgent need for non-invasive technique for diagnosis and therapeutic development for NASH. So NASH actually is very heavily invested and a very big market. The potential drug market is about $20 to $35 billion. And currently, there are 195 treatments in the pipeline. And you probably know there are a lot of announcements in recent years in terms of collaborations and companies collaborating with each other to develop drugs, or even they have companies buy small companies to bring up their pipelines. So you probably know Intercept has the most advanced drug at phase 3, and Gainier is the early player, and Allergan is also the early player in the space. And then everybody else also get into this space as well. You probably know, like Pfizer, Novartis, Merck, and BMS. So in other words, it's almost everybody is looking into this space and trying to develop a drug for NASH. So our approach is different from traditional pharma and biotech companies. We're counting on to develop a diagnostic assay for NASH. And our goal is to differentiate NASH and NAFL at a very early stage using mass spectral technologies. And we would like to be able to use this in clinical diagnosis in a routine basis. And then the next thing we would like to do also is the home run for the purpose of biomarker analysis is to use it as a surrogate endpoint for therapeutic development. And I think this is what we really need to do in the pharmaceutical company is to use different, or this is going to provide a novel platforms to develop drug. In light of we really don't have validated target anymore. And by doing this, we will be able to show the value of biomarker analysis in drug development, and we're very hopeful that that may be the alternative platforms for drug development. And to do biomarker analysis, and our strategy is to collaborate with distinguished researchers in academia, and we have collaborators at Pacific Northwest National Laboratory, that's a DOE national lab. They have cutting-edge technology in mass spec, and also have a collaborator in St. Louis University. He is a leading expert in NASH. He's a physician in St. Louis University. We also have collaborators in Brown University. So with this strong team, we are very confident we could develop novel assays for NASH, and I would think that could be our exemplary approach to tackle disease using biomarker analysis. And with that, if you would like to know more about our approaches and where we are and our collaborators, I'm going to be here around, and please feel free to talk with me. And we are applying for NIH grants, but I think with background from biopharma and the pharmaceutical industry, I think the government is moving very slow. So I would like to see if we could get more funding so that we could try more things. And with our collaborators, we have so much things to do. Thank you.
Thank you, Pauline. Thank you for a great presentation. I will now hand over the microphone to Latrax. She will Irina will present her research on a new way to treat epilepsy. Thank you.
Thank you, Alex. And first of all, I want to say that we are really happy and proud to be a part of Bio-Incubator in the Mansfield. And the second one thing that I want to say is that I'm sorry for my English. But I will try to do as better as I can. So, my name is Irina. I'm from Ukraine, and I'm a neuroscientist. This year is the first year of my PhD program, and I'm here to represent my company Latrax from Ukraine. So this is a startup company which developed a neurostimulator. This is a medical device for stimulate some parts of nervous system, which includes nerve, deep brain structures, and spinal cord nerves. So the first one that I want to say is that we have really big trouble with neurosurgery diseases in our world. 50 million people suffer from epilepsy worldwide, and this is 5% of Earth's populations. 75% from these people do not get treatment because they live in a middle-income or low-income countries, and we have real treatment gap. This is about epilepsy, but with some different diseases we have really bad statistics too. So we have drug treatments, and we have something like another way to help these people, but this is really high cost, and they do not get paid for this. So we made a team which includes neurosurgery. Konstantin Kostuk was the first one Ukrainian surgeon which provides clinical trials with neurostimulation, and he was implanted the first stimulation in Ukrainian territory. And we have engineers for hardware and software, neuroscientists, and laboratory assistants. What is this? What is stimulation is? This is a little device which implant into the human body, into the muscle, and consists of generator which generate electrical impulses, and for electrode it's connect with nervous vagus like this, for example, or with human brain structures, or with nerves near the spinal cords. So this type of therapy can provide a normal vital activity which has real bad situation in their health. So we do the 3 types of stimulations, and we make 3 types of electrodes for every type of stimulations. It's really specialized to every patient manufacturer because it can be every size, every large, every weight, or something like this. Today and right now we are on the stage of the working prototype for VNS stimulations. This is our working stimulator, which now continue to preclinical study with rats. And we have additional stuff to the stimulator. This is a medical programmator for clinical doctors use and for clinical staff use, which can be connected with computer, with device, with mobile phone or something like this. And we have transmitter for patients which have to do some viruses too. So what about price? We have a great solution with our engineering filed. We have a working prototype which have energy efficiency more than 30% if compare this with devices in the market today. The next our steps is provide a preclinical study and started to clinical trials. And we're going to provide engineering and some technical studies too for this device. So if you want to know more about us, please contact us or catch me after the presentations. I want to say thank you, Alex and Bruce, for invitation and for this time. Thank you very much.
Fantastic. Thank you so much, Ira.